Hello, everybody. This is Dr. Radialis from the Georgia office. Um, Today, I want to talk about Ashermann syndrome. It is not a widely known situation. Essentially, what it is when there are adhesions inside the uterus of a woman, and there are multiple reasons why this happens. Today, I saw one of my beautiful ladies that's battling this. We are making baby steps in the right direction, but it can be a challenging situation. So, so Asherman syndrome can happen after any type of pelvic infection. It can happen due to trauma. It could be trauma due to GYN procedures, abortions, miscarriages, DNCs. Sometimes even removing a fibroid inside the uterus, we need to be very careful because then you're creating raw surfaces can just stick together and close up an area. I've seen that happen. And then it can be done due to endometrial ablations, like my patient today. She had an endometrial ablation earlier on, and now she's remarried and she wants to have a baby. So we're working really hard on getting her uterus back in order. Um, in the traditional world, you have to go in and cut the adhesions. Now, the problem is that in surgeries, in the surgical world, period, um, when you do that and you cut adhesions, um, reform, they can reform, and not only they can come back, they could come back worse. So it's a very fine line between cutting and trying to keep it open, and there are different techniques described on how to try to keep that uterus open after it has been successfully reopened, right? So a lot of times the anatomy is so distorted that you need either laparoscopy and or ultrasonography at time of surgery, because the what you normally expect during a hysteroscopy, you don't really find. So in severe cases, even though ovarian reserve might be completely normal, they don't even see a period anymore, and that's occasions like when you do an endometrial ablation, that's kind of what you want. You want to destroy the lining. But that's one of the presentations. You can have Asherman syndrome and having a totally normal period, if it's a mild case or the segment that's closed down does not interfere with the exits, kind of towards that lower uterine segment or the cervix. Um, or you can have lighter periods and still have too much adhesions in the uterus to support a pregnancy. Okay. So now that I have kind of discussed what the issue is, let's talk about solutions. I am a fervent believer that problems are presented as challenges to look for solutions. So, like I was saying, traditionally you go in, you open it up, then you have to put some sort of gadget in there to keep the uterus from closing back down while you're trying to rescue the endometrium. The endometrium, I like to see it as grass. For those of you that have a backyard and grass, you know that sometimes it can get patchy, right? Where you have areas that the grass has died. So imagine that's where the adhesion was and you cut it off, but there's no endometrium there. So what we're trying to do with all of the different techniques is actually allow the grass or your endometrium, right, to cover up, to grow and close the defect. Sometimes that happens faster than others. The literature says that it could happen as fast, depending on the amount of adhesions, it can happen as fast as 7 days, but some people will need to have the catheter in or the device in the uterus for up to 28 days. So sometimes it's, it's a hit and miss. And then sometimes there's partial adhesion reformation after the hysteroscopy, where you have to then have multiple hysteroscopies in order to slowly correct the issue, especially in severe cases. Okay. And then what do you do to try to cause the endometrium to grow? Traditionally, you would do high dose estradiol for several weeks to try to stimulate the lining to grow. And then I personally really like to support the uterus with supplements. Those of you that are working with me, you know, I always talk about glandular. So I will have some uterine supplements, vascular supplements to help channel fluid to the uterus. So acupuncture at the same time that we're trying to get that uterus to heal, heating pads, Viagra, and then PRP. It's huge. In the more alternative side, we can do enzyme therapy in order to, you know, kind of prevent adhesion formation and potentially release any adhesions that might still be there. Okay, so those are a few things that can be done with Asherman's. Um, and in the majority of cases, they do have, especially if there's any lining left, they do have a good chance um, of, you know, having that regrow. And then we go into the question of autologous stem cell therapy. There are different techniques. I did go to a seminar once where the patient had partial, okay, she had pretty severe Asherman's, but she still had periods. So what happened, and this is experimental, unfortunately, it's not widely done. They took her own endometrial cells, right, and then they multiplied it in a lab and put it back into her in order to create like seeds in the areas where there was no growth, and then potentiate further growing. Okay. If this is something that is happening to you, feel free to reach out to me and we can go over your case and what can be done to have you have successful menses and eventually a successful pregnancy. Once the endometrium has been reestablished and there are menses, we are pretty much good and you should be able to get pregnant and have a baby. Now, because there was some issues with adhesions, we do have to keep an eye on placental issues and potential placenta accreta, which is that the placenta of the baby goes a little too far into the muscle, just because the endometrium might not be completely normal because of the history of adhesions. So, but for the most part, you should be able to have a successful baby if we are able to get this all good. All right. So I'm going to go over some questions. So I'm going to address, so para las personas de habla hispana, mañana por la mañana, hago Facebook en español. Probablemente empiece a hacer Facebook en español en algún otro horario, porque me han pedido varias personas que haga Facebook en español. Entonces, estoy abierta a sugerencias de horario. So I'm just saying that the Spanish community has asked me to do the same forum. I used to do both English and Spanish at night. So I'm welcoming suggestions of what the best time for the Spanish crowd. All right, so question number one. Last week I mentioned that I have continuous cysts. A couple of days ago, we did the prolactin test and found it's elevated. This prolactin causes ovarian cysts and suppress ovulation. It will mess up with ovulation. 27, a prolactin of 27 is no crazy high, but that's one of the reasons we're always watching for it. However, having continuous elevated prolactin not only will cause irregularities in the functionality of your ovaries, but it could also be a sign of something more serious like a pituitary tumor, pituitary adenoma. So that does need to be checked. Does ACG priming needs to be done subcutaneous or intramuscular? It's done subcutaneous. It's a very small amount. It's really, 0.12. So I usually tell people to do 0.15, because the insulin syringe, it's just easier to do 0.15 than to find the actual 0.12. And then it's an insulin needle. You put it into the fatty area of your body. Question number 3. Very organized, Mr. Ramesh or Ms. Ramesh. Currently, I am using leuprolide acetate 5 units to suppress ovarian cysts. Can we do ACG priming? Yes. So what's the difference between ACG priming and omnitrope priming? Human growth hormone will make cysts get worse in a lot of women, especially when you're handling very, very low ovarian reserve. I've seen that instead of helping the ovaries do better, it just gets them to do cysts, okay? The ACG priming, what it does is an indirect luteinization, right? Because the ACG is very similar to LH, and then it causes natural increases in testosterone, and so it indirectly, okay, it's like doing DHEA, but without doing the hormone replacement. I like it better because it's more physiologic. You're not going to overdo it, but you could correct a androgen deficiency, which is testosterone or DHEA, okay, without getting a beard. I suspect I have endo, but don't want to do laparoscopy. What would you suggest to get an FET treated as such? If you suspect that you have endo and you don't want to handle it, I mean, you don't want to have laparoscopy, then just, do Lupron and, or Lisa, do it for at least 2 months before you do a transfer. You can also do PRP to help the lining, to decrease the inflammation inside the lining. People forget that even if they have silent endometriosis, the reason that you can kind of figure out you have endometriosis with the Receptiva is because those inflammatory markers are not only in the endometriosis implants outside the uterus, but they're going to be inside the uterus too. PRP is fantastic for endometriosis. They think of PRP as, oh, it's to get the lining of the uterus thicker, but that's not its function. All right. What it does, it facilitates functionality, and it's a antibacterial, microbial actually, and it'll decrease inflammation in the area that is used. And then there are certain supplements in the natural side that also help minimize endometriosis and will not hurt an embryo transfer. Those are the things that I would do if you want to bypass a laparoscopy, which is the gold standard for diagnosis. My thoughts on IVIG. I have 3 failed implantations transfers. The only thing I have against me, I know it's grave disease. Wondering if it's something that's worth the money. Honestly, it's super expensive. I think that we can handle your Graves' disease some other way, including natural. Okay, I do a lot of natural health, natural general endocrinology. You're better off using stuff like Plaquenil, prednisone. Get rid of. It's very important if you have Graves' disease. Get rid of the gluten. Gluten potentiates. It really flares up autoimmune diseases with the thyroid. So keto diet, just something as simple as getting off all grains, could bring that inflammation down. So I don't think IVIG is worth the money in your case. There's a few cases that that's necessary, especially with more of the connective tissue and blood type of autoimmune disorders. What's your best suggestion for supplements or priming for someone with normal AMH and poor egg quality? So I suggest 1 to 3 months of priming for anyone that is embarking on an IVF mission. And the reason I say that is I see IVF like the Olympics of fertility, right? So if you're going to a major competition, you don't go untrained. You don't go not prepared. So you're going to be doing a very intense treatment. that is very expensive. No matter if we are the most affordable, it's still quite a few $1,000s. So I recommend everybody to plan ahead and get their body to the best health possible, to have the best outcomes. So get off the grains. Grains are not good for your endocrine system. I know they're everywhere. Okay. We just left the holidays behind and all the cakes and all the stuff. They were there and calling our names. But if you are in the fertility journey, then you need to do the diet. It's very important. And then you can do the CoQ10, the food-based prenatal. Vitamin D is crucial for ovarian function. That's why we bug you guys so much with it. Then you can do glandulars. There's a few companies out there. I usually use Standard Process because I trust them. But there's a few good companies out there with glandular therapy. And PRP. I mean, I have seen miracles with PRP. PRP is your own. It's your own protein. It's your own healing proteins that will call your natural healing mechanisms to repair whatever needs to be repaired. So it's accelerated healing and improved functionality wherever you put it. Okay, I've used PRP for over 12 years. I actually injected my mom's knees this weekend. She had bad knees. She had a knee injury a few years back that it was driving her crazy, and I started injecting her about 2 years ago. And she was pain-free for over a year, and then she was a little tender, and she's like, "Please go ahead and inject me." So, Happy New Year, Mama. Is ACG priming dosage 125 units? Yep. So 1 vial, yes. 1 vial of Novarel of 5,000 units should last you about 40 days, give or take. When should I do PRP? You can do PRP serially. There are different ways of doing it. If your tubes are open, you can do the high volume technique, which is the technique I created about 10 years ago, and you can ask me more about it or just text me through Messenger. You can do the intra-ovarian PRP. That one is a lot more invasive, requires at least sedation, and it tends to be more expensive as well. And then you can do it 3 months in a row in the follicular phase. What does that mean? So right after your period and before ovulation, so roughly between day 5 or 6 of your cycle to day 12 to 13. Okay. All right. So just going back to the case of Ashermann to close up our session today. And the use of PRP, and I'm going to go over this again. It's very important because I've seen people give wrong information concerning how PRP works. PRP does not cause lining to get thicker like crazy. Like, you put PRP and it'll thicken up, and you more PRP and it'll thicken up. PRP will help the functionality of the lining. So if it's too thin, it'll make it thicker. But if there's the issue is inflammation, it'll get it down to, it's kind of trying to bring it all back to where it should be. Okay. So if you're having, let's say you're handling like the endometriosis lady, if you're handling endometriosis and inflammation inside the uterus, okay, then the PRP will not make the lining thicken up abnormally, but it'll help the lining, the endometrium, work better and bring down the inflammation. So going back to the Ashermann's, same thing. It'll try to restore, it'll stimulate the body to use the mechanisms to restore the normal architecture of the lining of the uterus. Okay, that's how it works. It is your natural beacon of emergency signal for healing and repair. All right. Okay, I'll take two more questions. Intralipids versus Omogen. So yeah, so we used to do just like I can't remember what the brand was with the intralipids, and there were a lot of people with soy and nuts allergies, so they have changed to the Omogen, which because it's hypoallergenic. I can't remember what it's based on, but it's supposed to be hypoallergenic. And so it'll work exactly the same way. It's just the source of the fat that you're putting through. That's it. It's like omega-3, for example. It's omega-3 whether it comes from the fish or it comes from the flaxseed. Does creatinine affect IVF? My creatinine is 0.56. So your creatinine is a little low. That means that you're excreting it more. So I would suggest it's not going to affect your IVF, but it's a sign that your kidneys are flushing it out a little too fast. So you might need some kidney support. There's a lot of really good naturopathic kidney support out there for you. Again, for the Spanish crowd, I am I'm asking you guys to give me suggestions of different suggestions of times that it would be good to add a full Spanish video. I do a short one on Thursday mornings. And if anybody has any questions about the subject of today, Ashermann's, you're free to reach out to me and send me a message. If you want to talk to me for whatever reason, again, you can send me a message. And like I said earlier, I am Dr. Verdialis. I am the Georgia doctor. So happy New Year, many blessings. I hope 2023 fills you with wild adventures and crazy miracles, surprises you beyond your wildest imagination. And I will see you guys next week. Bye bye.